My name is Dražen. I work at the Cardiology department at University Hospital Center Osijek, and I'd first of all like to thank the organizers for this wonderful meeting and for having the chance to present our case report. It's going to be a much simpler one than the one so far, but I'd like to touch on a topic that we think is important, which is what Professor Babić mentioned yesterday and on Friday, which is the ECMO network. So, to start with the H&P, we admitted a 40-year-old man to our CCU with decompensated heart failure. He's been experiencing increasing dyspnea and leg swelling for the last couple of days. He was in our ED a couple of weeks ago with the same symptoms. Unfortunately, he declined admission at the time. He's obviously not doing that well. He has a pretty severe prior medical history. He has non-ischemic DCM, which was diagnosed 8 years ago. This was in 2021. His father has also non-ischemic DCM and HFrEF. There was no genetic testing available at the moment. The patient was admitted in 2017 with acutely decompensated heart failure. The ejection fraction was around 30% at the time with a dilated LV and normal coronary angio. Afterwards, he got a ICD in University Hospital American in 2017 as part of primary prevention. He also has paroxysmal AF, and he's diabetic with G2 diabetic nephropathy on insulin. This is his medication at the time, which was relatively decent, although he got, for some reason, Pafenon from a private cardiologist. But unfortunately, his therapeutic compliance for the last couple of months has been really questionable, especially with the DOAC he was taking. So, upon physical examination, he was tachycardic, dyspneic, orthopneic, diaphoretic on admission with distended jugulars. He had a real irregular and quick pulse of around 150 per minute, crackles above both lung bases. His liver was slightly enlarged on palpation in a scratch test without any pain. He was cold to the touch. He had bilateral edema, so he was in the wet and cold phenotype. His BP was 70/50, his MAP was 57, and he was saturating decently on 4 liters of oxygen. So he was obviously in distress. In his ECG, he had a quick AFib with rapid perfunctory response of around 150 with no significant changes pointing towards an acute myocardial infarction. Since he wasn't taking the DOAC, we did a CTPA on admission, which was fine. You can see it there. So nothing spectacular, but they did note ground glass opacities and dilated hepatic veins as part of congestion. He was sent for an abdominal ultrasound in the ED because of the labs, which you can see down here. There was just a diffuse liver lesion and dilated IVC, and there are dilated hepatic veins as well. You can see he had quite the liver lesion in his labs on admission with an increase in creatinine. His baseline was around 130. He was at 304 now. Slightly elevated high sensitivity troponin, a bit of hypervolemic hyponatremia. The BNP was also elevated around 3000. His lactate was normal after we started him on the butamine, and pH was normal in his ABGs. This is his chest X-ray on admission. You can see the ICD in situ there. It was reported as nothing special, cardiomegaly with no congestion or infiltrate on his lung parenchyma, which was sort of dissociated for the clinical presentation because he was obviously not doing so well. We know that the lung ultrasound is much more specific and sensitive than chest X-ray in acutely decompensated heart failure, so we proceeded to POCUS, which we do in most of our patients now in the CCU, luckily. So we found confluent B lines on his lung ultrasound bilaterally, consistent with pulmonary edema. His LV was dilated, severely globally hypokinetic with an EF of 15%, reduced LVOT-VTI of 13 centimeters, which was averaged because he was in AFib, and moderate functional MR, and he also had a dilated RV with a TAPSI of 12. So the RV wasn't doing that well either. The IVC was distended, obviously non-collapsible. The hepatic veins were dilated, as you can see on the lower picture, and he had also small bilateral pleural effusions. So this patient was obviously not doing well. He was admitted sometime in the evening. He got an ART line, a CV line, and he responded quite well to the butamine. It was up titrated to around 8 micrograms per kilo per minute. He got, after the MAP stabilized, he got diuretics in a continuous infusion and a low molecular weight heparin in a reduced dose due to the AKI and congested liver with anti-factor A monitoring. So his MAP was fine till the morning. His pulse dropped to 130. He was feeling a lot better. He had very little dyspnea. His diuresis was decent, around 40 to 50 milliliters per hour. So this was basically what we had on day one. So we got a congested liver lesion, increase in creatinine. The lactate was normal on the butamine, MAP was increased. So that was the first day of admission. The next morning when we saw him in our rounds, he was stable now on 9 micrograms of the butamine. He had normal sets on 2 liters of oxygen. So obviously we were thinking about the exit strategy for this patient. He's 40 years old. There's a lot of things we could do for him, not in our center, of course. So he was definitely a very good heart transplant candidate. This is a table from our heart failure guidelines, and he obviously has at least 3 of these criteria when we should call for help for our referral center, which is University Hospital Rebro in Zagreb, with who we have, I think, a really good correspondence for these sort of patients. And after the call, he was agreed for a transfer in a couple of days. This was COVID times, so the coronary care unit in Zagreb had a lot of ECMO patients at the moment. He was stable, doing well. It was deemed appropriate for him to wait for a day or 2 until he had a bed open for him. So we would classify him that morning at Intermax 3. He was stable but inotrope dependent, which was fine at the moment. So this is where we were with the labs. He had another increase in the liver LFTs that day. Creatinine increased also to 367. A mild increase in the troponin. Lactate was still fine. MAP was fine. Heart rate was down. He was on basically the same dose of the butamine, let's say an intermediate dose. We were quite happy with the response. This is day 3. So the patient is still stable or dependently stable, dependent on the butamine, with the same sort of diuresis, normal sets on room air, feeling relatively well. Another call to our friends in Zagreb, and he was basically arranged for a transfer the day after. The lab work was fine. We managed to down titrate the butamine to 7 micrograms per kilo per minute. Heart rate was about the same. He was doing quite well. The MAP was fine. But of course we wouldn't be here if it was all that good. In the evening he had a further episode of quite fast atrial fibrillation, around 180 per minute, with worsening hypoperfusion and dyspnea. The on-call team gave him amiodarone 150 milligrams IV. The AF slowed to, let's say, 140, 150 per minute. They still needed to up the butamine dose, but because the hypotension was getting more and more profound. His MAP dropped to 59, his heart rate was still high, and the butamine finally had to be increased to basically a really high dose of 19 micrograms per kilo per minute. So he was definitely dropping for Intermax 3 profile to an Intermax 2, so he has sliding inotropes, and we definitely needed to do something that evening. That was around maybe midnight, let's say. We considered, I was at home, the on-call team called me because I knew something about the patient. I talked to our colleagues in Zagreb. We considered other pressors or levosimendan. He had an AKI. We did a short trial of norepinephrine. His heart rate increased like momentarily to over 150. His MAP dropped. So we were really limited with options. And we made a lot of phone calls to our cardiac surgeons because they're the only ones at our center at the moment who have ECMO capability. So we managed to finally persuade them because they were not really happy with this idea that we had a patient who needed ECMO. We finally persuaded them to implant peripheral VA-ECMO via the left femoral artery and right femoral vein, and call our colleagues in Zagreb and arrange for an urgent transfer on ECMO. So this is why I chose this case report, because this is the first and so far only ECMO transfer for our center. The patient did have a bad outcome, unfortunately, due to serious vascular complications. But the point would be, so we know that the cardiogenic shock and advanced heart failure pertain a poor prognosis in our patients. I think this shows that we do need a formal ECMO or shock team, similar to our primary PCI network, which is extremely successful. I think using MCS is going to be a necessity for an increasing spectrum of indications, which we saw during the last couple of days. It illustrates the needs for intra-hospital and inter-hospital collaboration. And I think it's about time we progress from a regional PCI center to maybe a regional ECMO or MCS center. Thank you.